weeks. Just a quick reminder for all of you about the PCICS conference that is going to start tomorrow. It's going to be amazing, a lot of nice topics. Please take a look on the program. I'm sure you're going to be will be willing to join these amazing meetings. And if you are part of one of these countries, you are going to have your registration for the meeting for free and 1 year of a PCICS membership as well. So please take a look. We are going to have more amazing things on this the last of this year. We are going to have on Friday, as usual, Dr. Robert Anderson talking about morphology of the congenital heart defects. This Friday is going to be slings and rings. So it's going to be a very interesting. And then on December the 14th, Dr. Silverman is going to talk about anomalous pulmonary venous connections correlating the images of echo and morphology. On December 17th, we are going to have an update on fetal cardiology. And then the last one of this year is going to be Dr. Anderson again, talking about the fifth pair for us in his morphology series. After that, we are going to have a couple of weeks of vacation. And we want to thank all of you. We made out of these very strange years something very nice. And we want to thank all of you who attended our webinars, to our amazing speakers, to the moderators, to our delegates. And we are really, really happy about what happened this year. And we really think that the best is yet to come. And we are going to have amazing things prepared for you for 2021. Now with you at the start of this series, Dr. Gil Vernovsky.
Hey, everybody. It's so great to see you this morning, this evening, this afternoon, depending on where you are in the world. I do want to echo everything that Grace has said. It's been a terrible year. There's a lot of pain everywhere, but we've been able to get a bit of a silver lining with the opportunity to give 80 webinars this year. We've reached about 16,000 different individual people in 125 countries. And we're really happy, very proud with what's happened with that. We're always open to ideas, so please let any of us know what you think would be important, other things such as duration of webinars, time of day, etc. I know there's a few people on, our good friends Parvati and Krishna Iyer are on in India, where it's probably 1 o'clock in the morning. So thank you very much. And the series has taken a lot of twists and turns, and I'm really happy about today, where I had the opportunity to invite 3 not only thought leaders in our field and fantastic clinicians, but just wonderful speakers who really think a little bit outside the box and have a great teaching style. And I'll be introducing them as they come along, but I do want to say at the beginning, Dan and Meryl and Sarah, thank you very much for participating in this. It should be a lot of fun. Hopefully we'll have a little time for discussion at the end. We're going to be talking about some topics that are not the proper dose of epinephrine or whether early extubation should be tried. These are going to be the things in our field that, and I don't know if I'm using the term correctly, Sarah, but the hidden curriculum, the part that goes on all around us that isn't necessarily taught. Sometimes it goes well, sometimes it doesn't. And I don't think we have the opportunity to actually put this stuff on enduring materials too often. So that's our goal for today. Before we start, I would like to ask everyone if you could either, let me just find this now, if you could open up another browser window or your phone, and you can either scan this QR code here, which will take you right to what's called AHA Slides or ahaslides.com, and then /GW Friends. All in caps. And if you join this, we'll have an opportunity to answer some interesting questions. I think we have almost 100 of us on the call right now, so I hope that we can get close to that number for this very quick poll and a couple of fun questions I want to ask you. And if any of the faculty, as you see this, can think of something you'd like me to add, just shoot me a text and I can add it during one of the talks and we can ask it later. It's a really fun thing that allows us to create word clouds and yes, no questions and multiple choice things as well. Looks like we have almost 40. Again, if I could ask one last time, if you could either open up your phone or another browser window If you open up your phone, you can scan that QR code. Alternatively, you can type in on your browser ahaslides.com/GW Friends. So we'll start with just a couple of questions so that we get an idea of where you live in North America, either East, Middle, or West, South America, Europe. It's all quite explanatory there. We took out Antarctica because basically every time we've done this, somebody said they were from Antarctica. And I think it was Tim Feltus, but I'm not 100% sure. So we're getting most of the people from North America that are responding. We have 44 of us. And then you can advance your questions there on your phone or wait till I advance it. But it sounds like the plurality of people are here in the eastern side of North America. I am actually on in Washington, D.C., the city of stability and government, and cherry blossoms 12 months a year. You don't have to answer this question, but it's anonymous. If you could tell us how old you are. Most of our webinars have been skewed toward yellow and green, but I suspect many more of the people are working that are during the day between 31 and 40. It's also helpful for us in the faculty, not being able to see the audience to get a rough idea of who we're speaking to. We have a pretty representative sample across the age spectrum. Next question is, what best describes your daily practice? All right, so there's 5, 6, 7 heart surgeons on, so I better be careful about what I say in my talk. It's good to know. So a lot of inpatient types of people. Next is your gender. Again, you don't have to answer this, but if you'd like to give us an idea. Roughly 2/3 women is usually what we see. Very good. Next question is, all right, I'm going to leave this up for a second. And I want you to be very deliberate, and I want you to count how many squares you see. And I'll give you another 10 or 15, maybe 20 seconds to count the number of squares you see. And this will be relevant in the talk that I give. I don't know where these hearts come from down there. I don't know if you all are seeing them, but there's this series of hearts coming up. Okay, so 5 more seconds to count the squares. What is that from, Grace?
You can kind of like this slide, as there's no answer. So that's this heart in the app. So I press it as well. More for you. All of our love for you.
I don't get this stuff. All right. Thanks. Everybody's got a number, right? So what I want you to do is tell me the number that you came up with. Well, that was a straightforward question, wasn't it? This is actually what I was hoping to see. That's fantastic. And we'll be getting into what this means as we move forward. Last couple responses. All right, so nobody picked 27. Interesting. Okay. Next is, how sure are you about that answer you just gave? I'm completely sure. I'm fairly sure. I'm mildly sure, or I am clueless. I have no idea. All right, so you may have recognized that we had 7 surgeons today. I am sure they are in the completely sure category. Always, never in doubt. May not be right, but never in doubt. Meryl, I'm going to get myself in trouble way early in this talk. I can already feel it. Okay, so now I'm going to get started with that as some background. And again, to the faculty, if anyone has a particular question you'd like me to put up there, just shoot me a text and I'll do it in between one of the talks if I can. And I'm going to start and go relatively quickly with this talk on cognitive dissonance and other human factors which negatively influence progress. I want to thank Tamara Katina. I don't know if she's on. She's a cardiologist in South America who asked me to put this talk on, and thank you for asking me to do it because I've not really had a chance to update the slides. I do want to go back to this disclaimer that none of us are immune from these human factors, particularly me. I definitely have not gotten these things down very well, but I try to work on them every day. When we do an M&M conference, we frequently talk about cognitive errors or communication errors or technical errors and system errors. And when I talk about human factors, I'm going to talk about these two specific issues, cognitive errors and communication errors. So the outline is I'm going to first, for the predominant portion of this talk about cognitive dissonance. And then I'm going to add two other things I'd like you to think about, which is weight and buts. And this will become clear as I move forward. So if we talk about barriers to innovation and our practice changes, we can think about this on both a large scale and a small scale. We talked about this earlier in the academy. As some of you may have seen this, but as a recap, Sidney Pollard once said that progress has this Victorian ideal, which is that it's the assumption in our Western culture that there's a pattern of change in mankind that consists of irreversible changes in one direction only, and that this direction is toward improvement. But as we have seen in a variety of situations, when you break that down into small increments, there's a decremental sine wave in many ways that proceeds over time. And I think most of us, we would agree, especially those of us who work in intensive care, that we want progress, but as a group, we tend to be very resistant to change. Just as an example, let's sort of think about it this way. In addition to that linear model that I talked about, there are also these periods in our field where seminal events happen, such as, say, cardiopulmonary bypass, which takes us to a whole nother level, and then neonatal heart surgery and hypoplastic left heart syndrome, nitric oxide. These are disruptive events that change our practice. And we want progress, but we are especially resistant to disruptive change. The editorials about Dr. Lillehei's cross circulation or the ethical issues around hypoplastic left heart syndrome are just one example of the resistance to disruptive changes. So in a large scale phenomenon, someone will have an innovation, let's say an RV to PA conduit during a Norwood procedure. And then there will be some early adopters, there'll be manuscripts, there'll be presentations, there'll be increasing use. But over time, there's going to be unanticipated variation, adverse outcomes. The people resistant to change will start with the I told you so, that was a bad idea, I knew it all along. Modification will happen, fine-tuning, et cetera. And that's how we move forward on a large scale, and it tends to be a slow, undulating process. But it's progress. Sarah Tabbitt wrote a great paper back about 15 years ago at our own institution at Children's in Philadelphia that really demonstrated this, where the shunt type was basically based on the surgeon's preference. And frequently we know this is our memories of our last bad case. So often what happens in intensive care is one situation or maybe two situations color your practice for the next 30 kids. And you could see this up and down approach to the RV to PA conduit in yellow versus the BT shunt. Now, sometimes these innovations are at a single center. That's a good example. Let's say we're switching our electronic health record from paper to electronics. And the first time you use it, or maybe we talk about a surgical procedure, it works great. Maybe the electronic health record was not a good idea. Anyway, let's say we have a surgical procedure, a cath procedure. It works very well. Then there's a complication, adverse event. I'll never do that again. But what about the papers from Boston Children's? And then someone will respond with the inevitable, I don't believe, or they used to, I don't believe their data. And this is the fundamental issue that I want to talk about, which is cognitive dissonance. So just as some background, and Dan, I hope you like this part, to compare the difference between harmony, which is a agreement or concordance, such as man and machine in perfect harmony. In music, it's the combination of simultaneously sounded musical notes to produce something sort of beautiful like this. I hope the audio is coming through. This is sort of how I feel walking into the intensive care unit in the morning. Everything is fine. Looking forward to working with my fellows. But then there's dissonance, and dissonance is inharmonious or a harsh sound or disagreement. And in music, it's a simultaneous combination of tones that sort of feels like it needs completion. You know that feeling when you thought the ICU was going to be okay today? And then you get that sense that there might be a little something hiding around the corner. The other thing with dissonance is that, here's a couple dissonant chords I played this morning. As you know, the longer it goes on, the more stress we have. And the more we want to, boy, that's horrible. The more we want to assuage that dissonance. And that was the background behind Leon Festinger's theory of cognitive dissonance, which is now, 63 years old. I have a copy of this book. It's really tremendous. And just to sum it up, it's when your feelings and facts are in opposition with either new data or old data, people will find or invent a way to reconcile them. The classic feeling that you have is like those chords that I just played before. It's as comfortable to us as hunger. And one way or another, this type of anxiety must be assuaged. These were Leon Festinger's words. Sometimes we have a cognition incongruity. It happens with smoking. The smoker builds a bridge from feeling to fact. He rationalizes that he'd gain weight if he stopped, which would also be unhealthy, and the risks have been exaggerated and so forth and so on. And we can do that very often. In 1954, people were asked if there was a link between lung cancer and cigarettes, and 86% of heavy smokers thought it wasn't, and only 55% of non-smokers thought it wasn't. And Meryl, I was talking to you about before how it's sort of impossible to not think about the challenges that various countries are going through with leadership issues. And this is an example of it, of a game of Dartmouth versus Princeton in 1951. Festinger's lab showed this film of the game, and the Dartmouth students saw mostly the Princeton's penalties, but the Princeton students saw mostly Dartmouth's. And because of this cognitive dissonance, facts, true facts, can be alternative facts or malleable. In our USA politics, people stay within their social bubbles. They're reinforced by social media. There's 24-hour political commentary, television, and it's reinforced ways to avoid cognitive dissonance. And I believe we do this in our practice. I tend to have conversations with people who have the same approach to patient care than others. We evolve that way in a unit. The background behind this theory of cognitive dissonance, I'm not going to go through too quickly, but Marion Keech was the principal. I am going to go through quickly. She was the principal figure in this, thought that aliens were going to come down from planet Clarion, and they were going to rescue her and those close to her. And what was interesting was after Leon Festinger and a couple of his colleagues infiltrated this movement, they watched for 3 months, and about 25 upper middle class people who led normal roles just basically quit their jobs and threw away their possessions and waiting for the expected flood, and they were adverse to publicity. And that's the important part. They didn't really want to talk about it. And then she received another message from Planet Clarion, remove all your metal, be ready, and then they didn't come. So what happened? All of a sudden, Mrs. Keech's face began to glow. She had just received a message from Planet Clarion that said there was no longer any need for the flying saucers to descend, and the world had been spared because of that particular group. And, you know, obviously, the group was relieved to hear that they weren't going to go off to another planet. But besides the face-saving explanation, what set off this theory of cognitive dissonance was what the members did in the following weeks, which is to show people how correct they were. Early, they were not really talking about it, but look how good we did because this didn't happen. So if more converts could be found, then this dissonance between their beliefs and the knowledge that the prediction hadn't been correct could be reduced. So negative psychological tension exists, and you'll see where this comes up in cardiology relatively soon. It induces what Leon called a drive state, And the drive state, I think, varies in intensity due to the importance of the issue, the degree of inconsistency, and I would say the seniority of the physician. And I'll get into that in just a second. Most juries decide who won the case 72% of the time after the opening argument, and everything they hear afterwards supports their preconceived conclusion. So management practices that we believe become established. I don't know if you have any of my colleagues have this, but I get asked the question, do you believe in, or this person doesn't believe in digoxin? I don't know what that means. Digoxin is right here. I believe in it. But data in support of current practices or beliefs is embraced, and conflicting data that results in this tension state tends to be dismissed or ignored. And as I said before, the dissonance is greater, certainly in me, if there's stronger investment. And I'll show you an example of that. If I've taught about a particular topic, or I've lectured or published on a particular topic, and then contrary evidence comes out, it's a very uncomfortable feeling. I want to believe that all Fontan baffles should be fenestrated. I believe that limited periods of circulatory arrest are no more harmful than equal or longer periods of bypass. So this paper comes out in 2002. I've had these quote beliefs for about 2 decades. Coming out of Dallas, wonderful study. And the conclusion was baffle fenestration was helpful. It improved short-term outcome. And I'm like, this is a great paper. I shared it with all the fellows, et cetera. But around the same time, just a couple of years earlier, was this group from Columbia, Daphne Sue is the first author, who wrote this paper. And in their experience, there was no evidence that a baffle fenestration or even a 2-stage approach with a bidirectional Glenn was necessary in a large cohort of patients. So of course, my mind immediately went to the groups weren't compatible. It was a retrospective review, the chest tube drainage result, all these other reasons to not be curious about how did they have different results than the results I was used to. Frank Hanley said in a great editorial once that talking about things like circulatory arrest have become increasingly unsuitable for polite and civilized discussion. Uncertainty invites controversy. We've all seen this in our own unit. It seems that the strength of dogma can be inversely proportional to the data that supports it. So if I go back 25, 35 years, I absolutely believed that these issues were important, that we had to keep kids intubated and sedated for days. We had to warm them rapidly. Seizures didn't carry any long-term prognosis. Much of this has been, if not all of it, has been shown to be wrong. So this is where the dissonance comes in. This is what I think most of us do in our practice. We think early extubation is a good idea. We think high hematocrit is a good idea. We think the bidirectional Glenn is good for single ventricle. We think milrinone's a good job. We think that decreasing length of stay, or we believe these things. We believe NIRS is helping us. We think steroids might be good. Some of these will be wrong, but thinking that they might be can give you yourself cognitive dissonance, this pathologic certainty. So you have to keep an open mind in what you do. You have to widen your lens. So this is called the cone and the cube. And imagine that one person is looking at it through a hole in the top and another person is looking at it through a hole on the side. And you only had that one view. So if you looked at it from the top, you would see a circle with a dot in the middle of it. And if you looked at it from the side, you would see a triangle. And in fact, you would be sure that you saw a triangle. And you might even argue with the circle person that your triangle is right. We see these situations frequently in intensive care where we will feel very strongly about an opinion through our isolated lens of intensive care or bedside nursing, for example. Here's a paper from the group up in Boston talking about regional cerebral perfusion about 15 years ago. At 1 year of age, the outcomes of patients undergoing regional low flow perfusion were similar to outcomes observed in children with circulatory arrest. This paper was presented in a national meeting, and the opening discussant was Dr. Ed Beauvais. And what I love about the Annals of Thoracic Surgery is that they record the discussions that happen in the microphones. And then Ed rose to congratulate you on this study. And our results essentially mimic those you have just presented. I'm sure that may have been a contribution as to why Ed rose to support that study. Tom Spray, my good friend, colleague for 18 years, was in the same discussion. And he wrote, "We always love these studies because it confirms my own prejudice." So at least we're putting this out there. We're saying what we believe. Here's another comparison of the lateral tunnel, which supported my views. Chuck Frazier stood up at this one, and he said that was a really elegantly presented paper, an important paper which confirms a lot of what I already believe. How about delayed sternal closure? Many places use delayed sternal closure. This was from a paper we did about 13 years ago. It's a survey of a large number of centers. And you could see this widespread, but for the most part, most centers will leave the sternum open in most cases. Sarah Pasquale and her team presented this work from the SDS database a number of years back that talked about at least one infection complication in almost 1 in 5 patients that had delayed sternal closure. To my knowledge, there has not been a trial that shows that leaving a stable baby from the OR with their sternum open actually helps, but it may increase the risk of infectious complications. Around the same time, we looked at 99 kids that had a stage 1 at Children's Hospital of Philadelphia. And our practice there was not to use routine delayed sternal closure. We only did it in 17 patients. And there was not a single patient that required reopening of the series. And when I would present this data to other places, there was, "It can't be right. I don't believe your data," all the other dissonant reasons as to why this wasn't true. And it may just be the way we were handling that. Milrinone, Tim Hoffman, first author of the Primacorp study. Very quickly, when he made his conclusion, I'm going to go back one, excuse me. The conclusion you could see here at the bottom was the use of high-dose milrinone reduced the risk of low cardiac output. Many centers changed to using routine milrinone, but this paper was done by John Costello, beautiful randomized trial, double-blind placebo-controlled trial. And that conclusion was that compared with placebo, nasiratide or milrinone was not associated with early improved outcomes. Now, I'm a big milrinone fan. So this to me was the best example of dissonance. I saw that and I was trying to reconcile what this means. So we're going to go back to that test. I'll check my time for just a second. We're going to go back to this test. So here it's going to fade off in about 15 seconds. And please remember what your number was. And we'll go through how many squares there actually are. Well, the first 16 are pretty easy to determine. And then there's the 17, the one on the outside. But there's also 21. Well, actually, there's 25, 26. And then if you look again, there's 27, 28, 29, and 30. So 30 might be the answer, but it depends on the lens that you're looking through. This is the cone and the cube. If you're looking at this through 2 dimensions, you see 30. But if you tend to look at things from a 3-dimensional view, see if I can get this to move now. No, okay. Now, if you make this a 3-dimensional cube, there's actually 27,000 squares. And then you could say, "Oh yeah, but you didn't tell me about that," or whatever. But you can see how that's cognitive dissonance. And you also could see how we tend to look at things through our own lens, and our lens is there to reduce our own cognitive dissonance. A couple of quotes, and then the rest of this talk will be in memes. Charles Kettering said, "If you've always done it that way, it's probably wrong. Be skeptical of dogma. The greatest obstacle to discovery, it's not ignorance, but it's the illusion of knowledge, the knowledge that we're doing this right. Rethink your preconceived ideas. Keep an open mind. It's impossible for a man to learn what he thinks he already knows." And then be aware of your own dissonance. James York said, "Be good at a plan B." That's the first step in the challenge I'd like to give you for later on. I'm a big Simon and Garfunkel fan, and this is one of the best lines in their song, The Boxer. "Still a man hears what he wants to hear and disregards the rest." So now we're going to talk about hearing. Actually, we're going to be talking about listening. Most people don't listen to understand. They listen to reply. Think surgical conference. The collective monologue is everyone talking and no one listening. It's been a little better on Zoom, quite honestly. People just don't interrupt left and right. But you know that people are just waiting for their chance to speak. At least most of us are waiting for our chance to speak. Try to be a little bit curious because we stop listening. My grandmother used to say this: you have 2 ears and 1 mouth. Listen twice as much as you talk. Recognize when your cognitive dissonance impedes your clinical judgment and you're not listening. So, case example. Just finished preparing the heart of surgeon of a 4-month-old child with tetralogy. There were no surprises in the OR. Redmond Burke shared these intraoperative images with me. Nice example of the VSD that is now closed. The patch there. No surprises. TEE showed no residual VSD, no RV outflow tract obstruction, came off bypass easily. Minimal inotropic support, was extubated successfully in the OR. And of course, the excellent TEE echocardiographer said that operation was perfect. Merrill, you taught me that. That operation was perfect. The next morning, the ICU staff tells you that the patient has gotten sick overnight. He's tachycardic, oliguric, acidotic, and we just intubated him. His echo looks okay, but I think he needs a cath. And that's when that harmony that you thought when you walked into the unit changed into dissonance. There are some physicians who might get a little histrionic with that response. And unfortunately, sometimes we'll take that out on the very well-meaning but somewhat timid pediatrician, as you can see here. And then this gets worse if there's history between the caregivers. And before long, it's not about the facts and it's not about the patient, but it's about other stuff, beliefs, history, the last case, whatever. Once it gets to that point, it sometimes is not salvageable. And we have to remember there's always consequences to our actions. And before you act, make sure you're prepared for those consequences. A discussion is to decide what is right. That's where we should go. An argument is to decide who is right. And we move in that direction. We stop listening. Brene Brown said it best: I'm not here to be right. I'm here to get it right for the patient. So I'm going to share it with you an acronym that I love called WAIT, which is why am I talking? Of course, my wife always says, why are you talking? That's a whole nother issue. When we talk, is it true? Is it kind? Is it necessary? Why am I talking? Does it need to be said? Does it need to be said by me? Does it need to be said right now? How many times do I need to say it? Think about, actively listen and think about your words. Why am I talking? It's one of my favorite ones. I think we talk too much and don't listen enough in general. At least that's been my personal experience. Thinking about why am I talking? I loved this meme. I seriously need a speed bump between my brain and my mouth. As I look back and some things I truly regret just saying so impulsively where I didn't have a pause between thought and speaking. Why am I talking? The space between hearing, thought, and talking is crucial. And sometimes we get judgmental. Why is my colleague doing this? Why are they pissing me off? Why are they saying that? And it's good to be curious and not judgmental if you can. And then the last thing I want to talk about, why are you hearing but not listening? And that's buts. This is the last thing. Nothing someone says before the word but really counts. Think about this the next time you hear someone saying this. I'll just say one thing really quickly. We've all had the evaluation by our boss that tells you 95% of the stuff you're doing well and 5% where it's opportunities for improvement. And frequently you didn't count any of the stuff before the but. But usually goes along with holding on to previously held beliefs. Jim Locke taught me this when I was a young fellow. It said, don't fall in love with your first diagnosis and don't choose the data you present on rounds to support what you think is happening. And that's the whole notion of dialectical thinking, or one of the ways. The test of a first-rate intelligence is the ability to hold two opposing ideas in mind at the same time and still retain the ability to function. So think about these two different ways of presenting a patient. The cardiac output is good. The NIRS is 65. Urine output is normal. Heart rate and blood pressure are okay, but the lactate's 4.5, as opposed to all that stuff. And at the same time, the lactate is 4.5. They feel different somehow. They feel, at least to me, they feel like I'm putting more weight on the lactate of 4.5 than any of the other stuff, rather than holding both of those concepts in my mind at the same time. You could use the word "and" at the same time. So this is another example. Is this red or green? Answer is yes, it's both. So close with 3 challenges. The first is work on being able to hold 2 seemingly opposing viewpoints at the same time. Be curious, try not to be dismissive. Try to realize every time you say "but" and think about what that means. Try to change that to "and" or at the same time. Also, you can't change it to "however" because "however" is just as discounting as "but." Second challenge, actively listen. Don't just hear. Be curious about your colleague's viewpoint, not judgmental. And if you find yourself adrenalized, ask why you're bothered, not why he or she is pissing you off, but what is it about the situation that's really getting you upset? And then the biggest challenge is to find one deeply held organizational belief and challenge it. Research, read, ask, explore all sides, see what you find. What are your deeply held beliefs? Are you seeing the whole picture? Are you avoiding cognitive dissonance? Are the alternatives possible, even possible? Are you digging in your heels and justifying others' behaviors as defiant or uninformed or not good? I would suggest you examine your style and be open to exploring other alternatives because we can't solve problems by using the same kind of thinking we used to create them. So I hope you enjoyed that. I went a little bit long because of the poll and whatnot, but we'll move right on to the next speaker. My dear friend Meryl Cohen, who I can see on the box. Without going into too much detail, Meryl and I have known each other for 25 years. Her office was right next to mine for a long period of time. She's an amazing clinician, amazing echocardiographer, and an incredible role model for so many cardiologists and surgeons and fellows across the country that she's helped train. She gave this talk in some way at the ACC, I believe, and I saw part of it and I asked her to speak today. Meryl, it's on you.
Thank you so much, Gil. Thanks everybody for showing up today. And can you hear me, Gil? Okay, cool. I'm really honored to speak in this session with such an incredible group of individuals. And these talks are very inspiring. And I find as I age that I'm drawn to talks like this more than even the scientific talks. So I'm going to talk to you today about women pioneers in our field. And I love to look back at history to sort of see how we got to where we are. So let me just hit this, okay. So when we talk about academic productivity and you look at it by gender in medical schools, you can see that men on average have more publications and a higher H index compared to women, but the amount of grant funding tends to be equal. And men are more likely to be partnered, to have children, and to be at the full professor level. And I can even look to my own institution to show you this example. Women tend to be at the assistant professor level, and as rank increases, their numbers decrease, while it's exactly the opposite for men. Within the field of cardiology in general, there is a major gender gap, and this gap is clearly much worse in the adult cardiology world, where you see women trainees make up only 20%, and female adult cardiology practitioners make up only 18% of the total number. At the same time, in pediatric cardiology, we tend to be a male-dominated pediatric subspecialty. But of all the pediatric cardiologists that are board certified in the United States, 2/3 are male. However, we can see this is going to change over the next decade. In 2002, about 30% of fellows were women, and now it's 50-50. Despite this improvement in gender disparity, There are only 6 women division chiefs of the 60 academic programs in the United States. Women pediatric cardiologists are paid significantly less than men. And this gender disparity is even worse amongst pediatric CT surgeons. They make up there's only about 10 in the country, in the United States, and make up about 3% of all cardiothoracic surgeons. The American College of Cardiology Women in Cardiology section recently surveyed cardiologists about job satisfaction and other factors over the last 2 decades, and this included adult and pediatric cardiologists. They found that overall career satisfaction was quite high. Women were more likely to be pediatric cardiologists. They were more likely to practice in non-invasive cardiology, to work in the outpatient setting, but they were also much more likely to experience discrimination. And in life, women were more likely to have no children, if they did have children, to require childcare help, and more likely to be single. And so gender disparity still exists in our field, and we need to recognize it and work to solve it. The issue is clearly better than it was in the past, but some of the data is still quite sobering. So I believe it helps to look back and reflect on those role models who have paved the way for us. So we can talk about those who came before and those who are our role models and mentors, those who are our colleagues, and those who we teach. And it turns out, when you think of those who came before, that the field of pediatric cardiology was really started by 2 extraordinary pioneering women. And the first I'm going to talk about is Maud Abbott. Dr. Abbott was born in Montreal, Canada. Her mother died when she was young, and her father abandoned her, and she went to live with her grandmother, who was her fierce advocate. And when she told her grandmother that she wanted to be a physician, her grandmother told her that she could be anything that she likes. During her entire life, she had to care for a disabled sister. Despite being valedictorian in classics at McGill University in Montreal, she was refused admission to the medical school because she was told that a woman going to medical school was, quote, nothing short of a travesty, unquote. So she decided she still needed to become a doctor in some way, shape, or form, and she went to medical school across town at Bishop, where she was awarded the highest honor, the Chancellor Award. She was the only woman in her class. When she graduated, she was told she would not be allowed to practice as an internist because she could not touch patients. In 1898, she became the assistant curator of the McGill Medical Museum, which housed a disorganized collection of pathologic specimens. And some other facts about her is that she was never promoted past assistant professor, and the staff refused to call her doctor. They called her Miss Abbott. As a result of her work at this museum, she developed an interest in congenital heart disease and devised a new classification system. And the famous physician William Osler visited the museum in 1904 and was quite impressed with her work and urged her to focus on these cardiac specimens. And he even invited her to write a chapter in his book, and she was the only woman of 104 contributors. This led to her writing and publishing her Atlas of Congenital Cardiac Disease. And you can still buy this on Amazon, and I highly recommend it. It's a fascinating tome. So this was the first document to really categorize congenital heart disease, and she classified over 1,000 specimens with correlation between anatomy and EKGs and specimens. And she was the first to adopt a physiologic approach to cardiac defects, even coming up with such distinctions that we take for granted, such as cyanotic versus acyanotic disease. And her work really laid the foundation for modern heart surgery, and she even coined the phrase tetralogy of Fallot. She had some novel concepts as well. She correctly surmised that congenital heart disease was the result of abnormal cardiac development. And here are some pages from this book. Here you see bicuspid aortic valve, transposition of the great arteries. You can see these x-rays, anatomy, histology, EKGs, and drawings. And here you can recognize this drawing. It should look familiar to us as one we use similarly today to explain the physiology of transposition of the great arteries. This is an en bloc drawing of an en bloc specimen of what is now known as heterotaxy syndrome or isomerism. The liver's on the left, the stomach's on the right, dextrocardia, 2 superior vena cavae, and transposition. Of note, this infant died of volvulus, and of course, we now know that about 1/3 of those patients have malrotation. So she took this on, and much of her recognition, unfortunately, came after her death. At that museum that she was the curator of was posthumously named for her. And there's even been a stamp named in her honor. The second woman I'm going to talk about is Helen Taussig. Of course, you can't talk about pediatric cardiology without talking about her. So she was born just around the time that Maud Abbott was getting going. So she was born in Cambridge, Massachusetts, and her father was a professor of economics at Harvard. And like Maud Abbott, her mother died young. She suffered from dyslexia and deafness, likely from a pertussis infection. And her father worked to help her overcome her learning disability from the dyslexia. Like Maud Abbott, she was refused admission to Harvard Medical School. But she was allowed to study histology in the back of the lecture hall so she didn't contaminate the male students. Interestingly, Johns Hopkins had started a medical school with donations from philanthropic Baltimore women led by Mary Elizabeth Garrett at the turn of the century. And the terms of this donation were that they would only donate the money if women were treated similar to men with regard to criteria for enrollment. So they had women in every class. And here you see one of the first groups of women in the class. Helen Taussig chose to go there and obviously established and made her very famous career in that institution. I include this picture on the right to show you that she didn't really use a stethoscope because she was deaf. She would put her hand on the chest of the child to feel the murmur with her fingertips to overcome her deafness. In 1947, she published a book called Congenital Malformations of the Heart, and she made this remarkable clinical observation that children with tetralogy of Fallot who had continuous murmurs were less cyanotic than those without. And here's the lay press interpretation of some of the work she did. A woman's physician's courageous research and imagination and the skill of one of the world's greatest surgeons have combined to bring hope that many blue babies, hitherto considered doomed to early death, may be saved. She surmised that a man-made patent ductus arteriosus could prolong life in these infants with limited blood flow to their lungs. So she pitched this idea to Professor Robert Gross, who was at Harvard, and who had done the first congenital heart surgery, which was closing a patent ductus arteriosus. And he immediately dismissed her. So she turned to her surgical colleague at Hopkins, Alfred Blalock. And Dr. Blalock had been working on an animal model of pulmonary hypertension using a vascular connection between the aorta and the pulmonary artery. He was only able to do that work because with the assistance of his surgical assistant, Vivian Thomas, who was an African-American and grandson of slaves who wanted to attend medical school, but had to leave school because his bank foreclosed with all his money during the Depression. And this is the landmark publication from their collaboration, the first 3 cases describing the Blalock-Taussig shunt. It really should be the Blalock-Thomas-Taussig shunt. And if you haven't had an opportunity to read it, it is an extraordinary document. I'm going to let Helen Taussig herself describe what it was like to pitch this idea to Professor Robert Gross.
Out do these things, so I immediately thought, well, if you can close a ductus, why can't you build a ductus? And that would help these children and keep them alive.
Right.
I didn't realize how much it would help them.
Yes. Well, did you propose that to Dr. Gross, didn't you?
Yeah. Then I went up, and it was in '39, after he'd published his paper.
Yes.
And after that, and my father was getting on, I went up and proposed it to Dr. Gross. And of course, he was in the first flush of success, of brilliance, of closing a doctor. He said, "Oh, yes, I built many of them. That's okay." And I said, "I think it'd be a great help to a cyanotic child." He was so enthusiastic of building a doctor, he thought nothing could be as stupid.
Enthusiastic about closing it.
Yes, but closing it. That's why put one in.
Yes.
That just seemed the most illogical thing that you could think of doing.
Just think of the number of the Blalock-Taussig shunts we've done since that time. Dr. Taussig also initiated the first fellowship program in the country, and she trained many of the next leaders of our field. Some don't know this little tidbit about her, though. Well, it's not really a tidbit, it's an extraordinary feat. She received the Medal of Freedom from Lyndon Johnson, not for her work on congenital heart disease, but for her testimony in front of Congress and some lectures and editorials she gave, including this one about thalidomide. Thalidomide, many of you will know, was a drug used for morning sickness in pregnant women that had never been tested in pregnant animals and was subsequently found to cause major birth defects, including fecomelia, absence of the extremities. She'd heard about these issues, and she actually traveled to Europe herself to see the consequences of this drug exposure firsthand. And she helped prevent this drug from coming to the United States and thus protected thousands of children from succumbing to these birth defects. I want to just make a sidebar note and give a shout out to Frances Oldham Kelsey, who passed away a few years ago at the age of 100. She was a Canadian-American pharmacologist and physician who was a junior reviewer at the FDA. And reviewing thalidomide was her first assignment because it was supposed to be an easy approval. She was pressured to let it go through by her bosses, and the company even threatened to sue her, but she refused to approve it because of her concerns about its safety. And she was given the award for Distinguished Federal Civilian Service by John F. Kennedy. And after her work, new regulations for the FDA were implemented. Helen Taussig has become so famous that she was even recently in a Jeopardy question. For those of you outside the United States, this is our most popular game show. Unfortunately, the contestant answered yellow to this question instead of blue. Here are some of the pearls that Helen Taussig imparted to her trainees, written in 1952, and just consider that they all really hold true today. Allow the child to lead as normal and active a life as humanly possible. Immunization should be given at the usual time. Education is important. Intercurrent illnesses are usually well tolerated. Heart defects in siblings are so low that subsequent pregnancies can be recommended. And women with congenital heart disease tend to tolerate pregnancy better than anticipated. Every single one of these is really quite true and really have held up. If you think about the next generation, I'll briefly mention Jane Somerville, another extraordinary person. She attended a boys' boarding school during World War II because most of the children from London were shepherded away because of the bombing. And she said she really learned to stand up for herself there. And anyone who has met her knows that she can really do that. Despite that, imagine this, that during her training, she had to ask her chief permission to get engaged to her husband. Some of her contributions is that she organized the first World Congress of Pediatric Cardiology. She classified pulmonary atresia and discussed the natural history of ostium primum ASD, which led to our early repair of that defect. She opened the first ward for children with congenital heart disease in Europe. And most important contribution likely is her development of the concept of GUCH, grown-up congenital heart disease, that children with congenital heart disease, if successfully treated, were going to grow to be adults, and we would need to care for them in that age group as well. Here is Jane Somerville's response to a male interviewer who had just asked her if she thought the tables were turned now that more women were able to attend medical school.
But they still, if they want their careers, it's very tough. So I don't know that the tables have turned, and I'm not sure. I've never really thought. I was very proud to be a woman. I don't want to be a man. Why should I be liberated to behave like a man? Couldn't think of anything worse. But nevertheless, I would like to be, if I'm doing an equal job, I'd like to have equal pay. And perhaps the most important thing is, I would like to be considered if I had equal ability.
Some mother greats are Mary Ellen Engel, another disciple of Helen Taussig. She ran the pediatric cardiology program at Cornell for 30 years, established the first subspecialty section of the AAP in 1957. She made some of the first clinical observations of the clinical course of double outlet right ventricle, heart failure and VSD, WPW. She was the first to use gamma globulin for Kawasaki disease and recognized that post-pericardotomy syndrome was related to autoantibodies. And then Jackie Noonan, who trained in Boston and practiced in Kentucky. Unfortunately, she recently passed away in her 90s. Again, the power of observation led her to notice that some children with pulmonary stenosis had facial fissures similar to Turner syndrome. And of course, that led to the recognition of the syndrome named for her. She was also, along with her mentor, wrote one of the first descriptions of hypoplastic left heart syndrome. And of course, Stella von Prague, who trained also under Helen Taussig, partnered with her husband, Richard von Prague, to develop a system to describe congenital heart disease that is used all over the country and called the von Prague method. And she was one of the most extraordinary medical educators of our field and taught hundreds of trainees in cardiology and cardiac surgery, and did it with a grace and warmth. And this is what it typically looked like in her registry. And then Roberta Williams in Boston founded the Echo Lab there. She figured out how to use echo to diagnose congenital heart disease, first with M-mode, diagnosing VSDs, and then 2D echo. She was the first to describe the subxiphoid or subcostal view and used it to diagnose such lesions as ASDs, AV canal defect, transposition, and the first to describe echo guidance of balloon atrial septostomy. Just think about every day in your echo lab, what you're doing is a result of the contribution of Roberta Williams. And she went on to be an early female division chief in North Carolina and ultimately department chair at Children's Hospital of LA. And then here is just an incomplete list of women innovators and leaders in pediatric cardiology who were only able to achieve their accomplishments because of people like Maud Abbott, Helen Taussig, and the others I've mentioned. And there's just not enough time to mention all these extraordinary people. But these women, through their intellect, values, and dedication, inspired and paved the way for my generation. And here I am with several friends and colleagues at a recent AHA meeting when we used to be able to get together. And two of these women are division chiefs and the others all hold national leadership positions. Of course, every once in a while we let a man into our group. For those who think that gender discrimination is mostly a thing of the past, here are just some of the statements that I heard as I've gone through my medical career. And so, you know, medical school is not for women to meet and marry a doctor, right? I didn't give you honors because the guys in your class are going into more competitive residencies and need it more than you do. Are you really pregnant again? How many children do you need? And you'll never be able to work part-time and get promoted at Penn. Now, these are really quite minor compared to what we saw these other women, what they had to go through. Yet they are completely unacceptable, and they definitely left an indelible imprint that I carry with me. And so then we come to the next generation, and this is just a small sample of that next generation of up and coming or already here women in the field of pediatric cardiology and cardiac surgery who are changing the way we practice our discipline. And each generation brings more, and the impact is truly great. So how do we improve the gender gap? We need specific women leadership programs, mentors and advisors dedicated to addressing these issues and concerns, and assuring diversity in academic programs in faculties and trainees, scientific session moderators and speakers, and national grant review committees. And we need to be able to have an environment that you can report concerns without retribution. And in conclusion, the women I presented have shared several characteristics in common. They all had curiosity and perseverance. So they kept at it when people told them they could not. They had an inner confidence when people told them they were no good. They knew they were good and they could move forward. They were able to step back and see a big picture view of a problem to help solve it rather than be down in the minutia. And they truly had a spirit of collaboration. They were able to succeed in their fields because of their ability to work with others. And they all had tremendous tenacity and grit. In other words, they could all dance backwards and in high heels. Thanks very much.
Meryl, thanks so much. It's a fantastic review. And as I've told you directly, and I'll tell you again, you're clearly on that list. We have to find a place in the slides for you to be. And it's wonderful to hear that incredible review. I think there's a question you might want to answer in the QA box. But speaking of fantastic women cardiologists and cardiac intensivists, our next speaker is Sarah Teal from Children's Hospital in Boston, who directs the fellowship in cardiac intensive care. You know, Sarah and I never worked together, but it sure feels like we have. We've spoken at so many meetings, and she's such a forward thinker in terms of how to advance the field. I thought it would be really terrific to hear her talk about what she's very passionate about, which is teamwork and training. And without further ado, I'll turn it over to Sarah.
Hi, Gil. Thank you very much. And thank you, to Sasha, and to Grace for putting this together today. And good morning, good afternoon, good evening, and good very early morning to all of you on this webinar today. Thank you for your time. Gil, you and I actually have worked together, although I was the administrative assistant in ultrasound, and you, I think, were an early attending, and we played on a team together. So I think this actually works out well for us.
At my age, memory just goes.
Well, there you are. I'm going to talk to all of you today about teamwork and training. I don't have any disclosures, but I do want to say up front that I do not consider myself the world expert on this. I consider myself passionate about this topic, and I'd like to discuss a lot of things today, but I hope more importantly, this will inspire some much bigger conversations at the national and international level about how we can do this for our trainees and ourselves moving forward. So in terms of what we're going to talk about, or I'm going to talk about in the next 20 minutes or so, why should we teach teamwork skills? I think all of us have some answers to that, but we'll go through that. What does teamwork look like in our environment? And how could we think about teaching teamwork? I'm going to give you some of the tools that I try to give to our senior trainees and see if we can expand on those moving forwards. So teams are ubiquitous, right? They can mobilize forces for good or for evil. And if you are able to have your team come together and work together well, you have quite tremendous power. And when you think about what we do in the world of pediatric cardiology, taking care of children with congenital and acquired heart disease, we're managing fairly rare things. And so the power of coming together, combining our knowledge and our expertise, our resources is incredibly important. It enables us to deliver care more effectively and more efficiently. And there's been lots of work out there in the literature, both in terms of formal training sessions, reviews of experiences of teaching teamwork. This is a great interprofessional educational collaborative, which offers opportunities for leaders to come together and discuss teamwork. There's open access resources where you can do different things, experimenting with teamwork and trying to improve teamwork. And of course, simulation has been lauded as a great way to explore teamwork concepts. But the trouble with all of this is how do we form a united language, a similar vocabulary? How do we come together in this formal environment, the simulation suite? How does that translate into the real world? What are the practical considerations in an authentic clinical environment? And how do we make sure we all have these same knowledge, skills, and attitudes? And so what hospitals and people like me end up doing is spending a lot of time and money investing in formal training. But the reality is, when it comes to that conversation you're having with your team in the unit, this is more the scenario, this is the norm. And too often we end up in this kind of situation, and we know that communication failures play a huge role in medical errors and the delivery of inadequate medical care. It also leads to things like burnout and job dissatisfaction, which are important topics to consider. And so for this, I like to look to the work of Amy Edmondson. Dr. Amy Edmondson has a PhD in organizational behavior. She's a professor at the Harvard Business School. And she's known for a number of important things. One of them is psychological safety, which we'll get back to later on. But this concept of teams versus teaming. And she uses the analogy of sports to distinguish between the two. So if you look at this photo, I know there are lots of soccer fans out there, so I'm not trying to upset anybody. I just chose a good photo. This is a professional soccer team. And these are more or less the same people working in the same positions every day, wearing the same uniform, consistently practicing together and competing together to achieve a desired outcome. They share the same vocabulary. They have the same playbook of potential things they can do during a game. They have the same rules in every game, and they have a very predictable environment. They get to play on this lovely green soccer pitch, and it's consistent and it's controlled. That's a team. Teaming is a different concept. This is the idea of a group of people coming together for a common purpose, but their roles, their appearances, their knowledge base, their experiences, their vocabulary may be vastly different. They may have never practiced together before, and they may work together once and then never again, or some of them may be more familiar with others but some may be completely new to the group. The environment can be quite variable, and it's frequently not ideal. Look at the grass that this team is playing on. And I would make the argument, and I'm quite sure that Dr. Edmondson would agree with me, that our lives in medicine, and then this is the ICU environment, but I think you could translate this into outpatient clinic, the cardiac cath lab, and occasionally even the OR, that our lives are more about successful teaming. And so this is the skill set that we need to focus on, or these are the skills that we need to learn about. And so this is patient rounds. You could talk about a cath lab case where you have imaging and surgical support in place. CPR event, certainly those are the first people in the room, and oftentimes it's a brand new group working together, or at least a group that's not consistently working together. And then even if you're talking about a committee forming or an educational group coming together, or a global webinar, our spheres interact. We move in and out of one another's spheres all the time. And successfully navigating this takes advanced skills that are inherently fluid and need to develop. And furthermore, when we look at ourselves and our learners, this is not what we look like. We look more like this. And even appearances are just one facet of an incredibly complex person, right? Each individual is a puzzle of all these different components. And when you think about how complex we are and the lenses through which we see things, and just like Gil pointed out, we're not surprised really that this is what often happens. And so I think of my job as the director of the training program in the CICU, and part of the training program for our categorical fellows is providing our trainees with tools that can help them navigate this incredibly challenging and fluid environment. And when you consider everything that we ask them to do as learners, we ask them to be teachers, leaders, put together complex schedules, manage technology, the electronic medical record, and we ask them to do all of this and be happy about it. It's pretty amazing that they are most of the time. And so what I've come up with is, well, think of these as kind of the ideal tools in your toolbox, right? They may be a very simple concept, but if you have this tool, it can be incredibly useful in all kinds of different situations. And so that's what I'm hoping to give my trainees and what I want to introduce you to today. So starting with some really simple concepts here. Everyone on the team, and I appreciate that on this webinar, there are also some APNs and people with surgical backgrounds, but everyone on the team should have a solid foundation of knowledge, and that is content knowledge, procedural knowledge for their roles, and then also knowledge about teams and human beings and human factors and the things that Gil was talking about in his talk at the beginning. This graph on the right, or this figure on the right, is based on the work of a Dr. Csikszentmihalyi. I practice his name quite a bit. He is a Hungarian-American psychologist, and he's well known in the field of positive psychology. a lot of people have heard about him in terms of this concept of flow, or being in the zone that gets talked about a lot in the popular press. And if you look at this graph, on the y-axis, you have challenges from low difficulty to high difficulty. And on the x-axis, you have skills from low difficulty to, or not, excuse me, lower skills to higher skill sets. And if you're in that flow, if you're in the zone, you're operating in a place of high challenge requiring high skills. And when you're in that flow, you are living in the moment, you are unaware of time, you are enjoying the complexity of the task, and you're not having to think about it. You're very comfortable being there. It's a really good place to be. And that's what we want our trainees and our faculty to be. And when we think about what we do for a living in pediatric cardiology, we operate in this high challenge place, right? We have complex anatomy, complex physiology, lots of different technology options, lots of potential surgical interventions. We have a high challenge existence. And we spend very little time in these bottom quadrants on this figure, right? We're in hopefully, we do not spend a lot of time being apathetic, bored, and unfortunately, not very much time being relaxed. We spend more time in these upper quadrants. And so our goal is to give our trainees and our faculty the skills that will get them towards that right side of this figure so that they can spend their time in flow. Because the reality is, if a senior trainee or a junior faculty member is comfortable with his or her knowledge base, their skill sets, and even their limits in those skill sets, then they don't get distracted by worry, anxiety, or stress. They can be open to the suggestions of others, including other providers from different backgrounds, family members on rounds. And this encourages safe communication and improves collective knowledge. All right, so next tool, adult learning principles and the importance of knowing yourself. So metacognition is thinking about thinking, which can sometimes get you into this funny little loop. But if you really think about how your brain works, it can be important to get to know yourself and these things that I call metacognitive mindfulness. So as a human being, what do I really know? Where are my knowledge and skill deficits? What do I need, or who do I need to help me fill in these gaps? How reliable are my thought processes right now? Am I incredibly hungry and I'm actually not focusing on this conversation at all? Am I thinking critically? Am I being misled by my own biases, implicit biases based on the other person's appearance, anchoring biases based on my experience with the last patient? Do I need to adjust my decision making? What could I be missing? Who can I look to for help, and how can I help others? And then looking back on experience, can I reflect accurately on that experience? And how can I obtain and how can I give others constructive feedback? And so one of the things I try to do with my trainees is explore this way of thinking. And what's nice about this is that it then translates into team metacognitive mindfulness. So in an environment such as on patient rounds, during CPR, in the cath lab for that complex case, what does our team know about this patient situation? What don't we know about this patient situation? Where are those deficits? How is this team functioning right now? Where are our vulnerabilities, and how do we need to adapt or mitigate those vulnerabilities? And what other resources should we consider? Are we still doing the right things to meet our goal? The plan that we started out with, is it appropriate still, or should we modify it? Is our goal, in fact, the same goal that it was when we started? So, team metacognitive mindfulness. And then this next concept is the fixed mindset versus the growth mindset. And I want everyone to embrace the growth mindset. Looking at the ages of the people on this webinar, and it was a nice bell-shaped curve, many of you fall to the middle or to the right, meaning above the age of 40 or so. And I suspect it's fair to say that many, if not most of us, grew up with this sense of a fixed mindset. You're born with talents, you have natural talents for some things, you aren't very good at other things. You should always be successful. Make sure you hide your failures. You have to be smart. That's how I certainly know that I was raised by very well-intentioned parents, I can tell you. But I think these days, the work of Carol Dweck and others has started talking about this growth mindset. And it's really a frame shift that we have to encourage in our trainees and in ourselves. So a challenge is an opportunity. It's a reason to get up in the morning, not a reason to hide under the covers. How do you acknowledge and embrace your weaknesses? Take a hard look in the mirror and recognize that you have limitations and that you have biases. And how are you going to either find ways to improve or work around those, or at least acknowledge them and recognize that they're part of your decision making? How can you give and receive constructive criticism and not have it destroy you? How can you hear all of that stuff that Gil was talking about before the but, and also recognize what comes after the but and sit together with those things in the same place? That your intelligence and your talent are dynamic and they have the potential to always improve. I cannot promise you that you're going to be a professional soccer player if you practice every day, but I can promise that you'll get better at playing soccer. You can prioritize learning over seeking approval. I am learning because it makes me a better clinician. It makes me a better human being. It makes me a better parent. And at the end of the day, I'm not looking for someone to stick a gold star on my head. I don't need that. How are we going to focus on the process, not the result? It's the journey, not the destination. And I know that sounds corny, but it's really true, right? Life is short. You might as well enjoy it. How can we be inspired by the success of others? The success of others is our group's success, and we should embrace it. And learning is a lot like athletics. You can train your brain to learn. You can say, I'm going to make my brain faster, stronger, better. The same reason you get on the bike at night to make your body faster, stronger, better. How is failure an opportunity for growth? And how can we persist in the face of setbacks, recognizing how difficult it can be and how embarrassing it can be to fall flat on your face? And how can you say, actually, well, okay, that didn't feel great, but here I am. I'm going to stand back up again, dust myself off, and come at it from a different direction. And that's what I'm trying to give our trainees and our learners as well. Because when you develop this climate of mutual support and psychological safety, that concept that Amy Edmondson talks a lot about, and I highly recommend her work, then that's a climate in which knowledge and assistance are actively sought and offered. And effective communication becomes the norm, not the exception. All right, next tool is leadership with a small L. And I know Dr. Penny is going to talk about leadership, and so I don't want to spend too much time here. But so much of medical education in the past has valued individual success. And this cartoon feels a lot like pre-med courses in America and New Zealand, the two places I can speak to, and I suspect other parts of the world as well. And so how do we overcome this framework of autonomy and shift instead to trust, collaboration, accountability, and embrace the idea that everyone is a leader, no matter what their job or title? And that's a huge leap of faith. Having said that, I found that my trainees really enjoy the leadership literature. So the work of Amy Edmondson, Brene Brown, Pat Lencioni, Jim Collins, Ryan Holiday, and others. And there's a tremendous amount of high quality podcasts and videos out there, which is a technology that many of our learners really appreciate because it's something they can do on their commute to work. And so for our senior fellows, we try to weave in these concepts of leadership over the course of the year, but we also have designated sessions where we talk about inclusive behaviors. It was nice that Gil talked a lot about listening because that's something that we tend to focus on as well. We also talk about why good leaders are good followers, the importance of being able to adapt and pivot as needed. And how can they, walking out of the door at the end of a 1-hour session on a Monday afternoon, how can they start influencing their environment so that we can do our collective best for the patients and for ourselves? And that involves facilitating, encouraging, and role modeling. And the role modeling is really the last tool that I wanted to mention today. And Gil briefly touched on this concept of the informal curriculum. And just to take a step backwards, if you think about all the things that we write down and publish on important websites about these are the things we're going to teach our learners. We are going to teach them the anatomic components of a complete AV canal and the surgical interventions timing and the postoperative management. That's the formal curriculum. And we're pretty good at thinking about the formal curriculum and arguing about which particular facets need to be included in a trainee's upbringing. What we don't tend to think about is what we're teaching our trainees that's not written down. And that's called the informal or hidden curriculum. And it's what we do, how we behave and interact every day. It's the working environment in which our trainees develop their professional identity. And they look to us as faculty and they look to one another for cues on the right behaviors. And we have to be more thoughtful about that. Modeling a growth mindset, acknowledging one's own limits, and really actually being transparent about your weaknesses and how you're trying to overcome them, and occasionally laughing about your own failures is important. This is a snapshot of the sort of the practical parts of what I'm talking about. I do a 1-hour session with our senior fellows every Monday, and I'm hoping that we might be able to expand this. And this is where this webinar is fabulous, because I think there's all kinds of great ideas out there. I'd love to hear them. But if you look at what we're doing, it's a combination of clinical content as well as some of these things that I was just talking about. The faculty or the moderators for each session are listed in that right column. My initials are ST, that's me, but more important, what I want you to focus on is some of these other people. So Dr. Phil Levy is a neonatologist with an interest in congenital heart disease. He meets and talks with our fellows through cases that involve congenital heart disease and the management of premature infants. How can we optimize care and bring those two spheres together? Stephanie Carlisle is one of our expert respiratory therapists and perfusionists. She's an ECMO expert. She comes in and talks with the fellows about ventilator basics. It's a safe place to ask questions. Tell me how a ventilator works. How do I think about managing a Fontan versus managing somebody in heart failure? Dennis Daniels is one of our PICU attendings, again, bringing together teams from different parts of the hospital. He also works in our ICU and talks them through respiratory physiology. And Monica Kleiman is an intensivist with expertise in transport medicine. So you can see we try to bring people in from different spheres with this idea that it takes all kinds of knowledge coming together. And then interwoven throughout this are some of the concepts that I've been mentioning and some of the tools that I've been mentioning. And we try to really put those into the clinical cases as well. So if we're exploring high-risk intubation strategies with Peter Lawson, we're not just talking about the physiology, the anatomy, the medications, but we're talking about what the room looks like, who's the team in the room, where are your strengths in the room, where are your vulnerabilities, and how can you offset those? And then some of the sessions, as I said, are dedicated to the specific topics that I just mentioned. And so at the end of the day, our trainees are managing an overwhelming amount of knowledge, and that's going to continue to grow throughout their professional and our professional lifetimes. And we owe it to our patients to give them the best in every facet of their care. And in my opinion, the future of medicine are interprofessional teams, and they have to function well. It's critical to capitalize on the expertise, the depth of knowledge, and the skills that are out there. And also when people understand that they have valid roles, that their contributions are valued, they have a sense of belonging to something bigger than themselves, that's when we're really happy at work. And this successful teaming results in increased energy, innovation, and shared commitment. And so we owe it to our trainees to give them the skills to do this successful teaming. And I wanted to finish with a quote, and I looked at a lot of the classic leadership quotes, but in the end, I actually landed on this one by Amy Poehler, who's an American comedian that many of you may know. As you navigate through the rest of your life, be open to collaboration. Other people and other people's ideas are often better than your own. Find a group of people who challenge and inspire you, spend a lot of time with them, and it will change your life. And I would certainly say that that is true for the people on this webinar today, and I'm looking forward to many opportunities moving forwards. I think 2020 has demonstrated how interconnected we are on this planet and our shared vulnerability. And this idea of teaming has to be something we all take on. So grazie mille to everyone, and thank you.
Well, Sarah, thank you. That was terrific. I love the shift that's occurred in our particular subfield, and you have put the care back in intensive care. And I particularly really enjoy how that balance has now come back to some sort of reasonable normalcy. in a very intense environment. So I really do appreciate that. That talk was full of information, and I'm glad this is a good opportunity for me to tell everybody that all of what we do on Congenital Heart Academy is on our YouTube channel. So you can look at these links afterwards and have an opportunity to share parts or all of this with everyone. Our fourth speaker for today probably needs no introduction, but I'm going to give him one anyway, which is my good friend Dan Penny, who's the chief of pediatric cardiology at Texas Children's. I think Dan and I met in 2009 at the World Congress of Pediatric Cardiology in Cannes, maybe before that. And either this is good or bad. We tend to think the same. To avoid my own cognitive dissonance, it was the first reason that I asked him to come, because obviously we think the same, so it must be right. Dan is a pianist. He was a champion pianist in Ireland back when he was in high school, I guess. We've had a chance to play a little bit together. He's showed me some great classics, and I've shown him a little bit of jazz. And that's sort of an introduction to this great talk that I've heard him give a couple times, and I'm really excited to hear it again on leadership. So Dan, I'll turn it over to you.
Thanks very much, Gil. I'll try to share my screen. Please tell me, Gil, when you see this.
I see it. If you could get a little closer to your microphone, I think it would be better.
Yep. Okay, good morning, afternoon, and evening, everybody. There was a lot of new things in the last few talks. My talk is going to have almost nothing new, because really all it's going to do is sort of look at some of the concepts that were described earlier with a slightly different spin. As Sarah so eloquently put it, there's a lot of interest in the role of team working in healthcare, and there's a huge amount of literature on the value of team-based care. Sarah mentioned somebody called Pat Lencioni. If you read his book called The 5 Dysfunctions of a Team, the foreword to that book is quite interesting to me. He said, if you could get all the people in an organization rowing in the same direction, you could dominate any industry in any market against any competition at any time. Whenever I repeat that adage to a group of leaders, they immediately nod their heads, but in a desperate sort of way, they seem to grasp the truth of it while simultaneously surrendering to the impossibility of actually making it happen. And Lencioni goes on to say that for all the attention that it has received, teamwork is as elusive as it has ever been within most organizations. Teams, because they're made up of imperfect human beings, are inherently dysfunctional. It's probably important as we start out to try and differentiate between a team and a working group. We all talk about our teams. This is our cath team, this is our EP team, this is our echo team. It's very important though, when we're really talking about teams, some very important feature is that a team really concentrates on mutual accountability and collective work products rather than necessarily on the basis of the individuals. So Lencioni set up the challenge about trying to find an elusive answer to what makes up a good team. And when I was growing up, this was the sort of team that I grew up with. And I hope these videos play. So I always thought that this was the ultimate team. You can see their seamless handover from the first violins to the pianist, the surgeons to the intensivist. And from the pianist to the second violins, the intensivist to the cardiologist. There's great clarity of role. I must have been at thousands of these concerts in my life. I've never been in the situation where in the middle of a Rachmaninoff concerto like this, one guy in the trumpet section stands up and suddenly decides he's going to play She'll Be Coming Round the Mountain When She Comes. Having said that, we do that all the time in healthcare because we really value our individuality as clinicians. So I thought that this would be a worthwhile model exploring to see how the orchestra could help us about how a team should work, and really how conductors would be able to guide us about how true leaders lead these teams. So I looked back into the history and I found the most famous conductor of the 17th century. This is a guy called Jean-Baptiste Lully. And here he is conducting. And you can see he's completely dominant. And he has this enormous stave that he hammers on the ground. And so this sort of depressed me when I thought about this, because this really suggested to me that maybe conductors are not good models of leaders. Maybe they're complete tyrants. And indeed, it's been said that most dictators and tyrants, really their real ambition was to be a conductor, but they really didn't make it. But if you look at Lully, you can see how dominant he is. And this sort of depressed me when I thought about this, until I found the greatest conductor of the 20th century. And this is a guy called Carlos Kleiber. And you can see this is a completely different dynamic. You can see he doesn't have the huge stake anymore. He's much less dominant. He's hitting his baton. And so this is a completely different atmosphere. He's not dominant. His symbol of his dominance, his baton, is now obviously much smaller, and he often hides it. So this led me to believe that maybe I could learn something about leadership from these conductors. Ben Zander, a great conductor, talked about his role as a conductor in the following terms.
Something happened to me when I was 45 that had a shattering effect on my life. It was a kind of road to Damascus event. I realized suddenly one day, having conducted for about 20 years and become quite successful at it, I suddenly realized one day that the conductor doesn't make a sound.
Oh, sorry, I don't know what's happened there. Forgive me. I'll try that again. I don't know how Facebook's...
I'm here today to talk to you about trust. My job depends upon it. There has to be between me and the orchestra an unshakable bond of trust, born out of mutual respect, through which we can spin a musical narrative that we all believe in. Now, in the old days, conducting music making was less about trust and more, frankly, about coercion. Up to around about the Second World War, conductors were invariably dictators, these tyrannical figures who would rehearse not just the orchestra as a whole, but individuals within it, within an inch of their lives. And I'm happy to say now that the world's moved on, music's moved on with it. We now have a more democratic view and way of making music, a two-way street. I, as the conductor, have to come to the rehearsal with a cast iron sense of the outer architecture of that music, within which there is then immense personal freedom for the members of the orchestra to shine.
Sorry, I don't know how that happened, but to go back, Zander talks about the idea that the conductor doesn't make a sound. His picture is on the front of the CD, but the conductor doesn't make a sound. The only thing that gives a conductor, as the leader of an orchestra, power is his ability to make other people powerful, and his ability to awaken possibilities in other people. Hazelwood, then one of the great operatic conductors, talks about this idea that trust is so important for him. He needs to have this unwavering trust between him and the orchestra. And the other thing that he talks about is that he just has to have a cast iron or very solid sense of the outer architecture of the music. And then within that outer architecture, there's immense personal freedom for the members of the orchestra to shine. And so we will explore some of these concepts in more detail. This is a comment on Claudio Abbado, one of the other great conductors. And this is another concept about leadership that I've taken from some of the conductors.
Der Claudio ist natürlich für mich eine absolute Inkarnation eines noblen italienischen Mannes. mit zusätzlich etwas, was es in Italien nicht so sehr gibt. Das ist
he has this kind of restraint,
also eine Noblesse noch dazu in
personal
das,
reticence,
was wir Zurückhaltung nennen, ohne vorlaut zu sein, aber doch an der
without
Stelle
being
in
self-assertive.
Präsenz und Wachheit,
He's always
die
present,
aber nicht
always
artikulieren
vigilant,
muss und
but
so
without drawing attention to the fact. So as I've learned about some of these concepts, I've tried to develop them within our team. And so let's, and this is the idea that we heard Jim Collins mentioned earlier on. Jim Collins talks about this idea of a level 5 leader. And this is a triumph of humility and fierce resolve. In other words, a level 5 leader is somebody who builds an enduring greatness through a paradoxical combination of personal humility plus professional will. A level 5 leader will be somebody who demonstrates a compelling modesty, will set up successors for even more greatness, looks out the window, looks in the mirror, not out the window, to apportion responsibility for poor results. Some people very foolishly regard this as being weakness, and that's a big, big, big mistake. But combined with this humility, these level 5 leaders, they have an unwavering resolve to do whatever must be done to produce the best long-term results and will settle for nothing less. And I think these are some very important concepts for us as we learn to be leaders. Let's go back to Kleiber and let's see him demonstrate some of these things. You can see he invites in this soloist. He gives him immense personal freedom to shine. When he introduces the soloist again later, you'll see something that is very interesting to me. He doesn't disappear. He's completely present for the soloist. He's not being self-assertive, but he's always present, always vigilant. And so sometimes you'll see people say, well, Johnny, you're in charge of the, a chief of cardiology, Johnny, you're in charge of the cath lab, it's your responsibility. And this is a sort of an abandonment. But Kleiber has this amazing ability to allow people shine, but still be there present with them and supporting them. And this is a very interesting skill that I thought he had developed really well. If you then think about it, if you develop this idea of trust and allowing people to shine to the ultimate fashion, then one day you may become like Leonard Bernstein. Stand there, he had developed this trust. He didn't make a sound. He let the members of the orchestra to shine. And for me, he has done everything you would expect of a great leader. So if you think about this, then maybe we could get to some teams where you really don't need a conductor or a leader at all. And there are some chamber orchestras that have been built like this. One of these orchestras is the Orpheus Orchestra. And this now tells us more about how team members need to behave and how they need to think about their work.
Each one of us is as responsible as a conductor for having an interpretation, knowing the score,
responsibility,
and being able to discuss those ideas with your colleagues. That's something that's very unusual in an orchestra setting.
And you really need to create a group consciousness.
It starts out with just the core of players who are the principal players for that particular piece, which is different for every piece. And once that gets developed within the chamber music group, the small group, it's then transferred to the large group. And that's one of the most difficult moments, is to take the small group's concepts and see how it's going to work with the bigger group.
And the group as a whole may sometimes reject some of their ideas, argue, question, deepen. And so every member in the rehearsal process and on stage absolutely has a say.
And so I think that if we've done anything good over the last 10 years, it's exploring this concept, this idea that every member of the team considers him or herself as responsible as the leader for the success of the team, developing this idea of a group consciousness and really learning together to be able to translate what we are trying to express in an above board way to through above board conflict to the other members of the team. There's a book written about this orchestra called the Leadership Ensemble. It's not called the Leaderless Ensemble. And the reason for that is that every member of this team considers that he or she is a leader. And so again, if we go back to Patrick Lencioni, he talks about some of these concepts, and he talks about this idea again about trust. In the absence of trust, what's going to happen is that if people don't trust you, if there's not trust within the team, then people will not feel safe to disagree, and there will be a fear of conflict. This above board, candid debate is extremely important. It's not a bad thing, it's a good thing, because if people are not given the opportunity for candid debate, then they won't be committed. If they're not committed, then they won't be accountable. If they're not accountable, then they won't focus on delivering the results you want. And so everything is built on this idea of trust. It's actually vulnerability-based trust. In other words, we heard Sarah talk earlier on about how it's okay for her to say, I didn't get this right, or I don't know what to do. We heard about that earlier on. And this is this idea of vulnerability-based trust. And so I think these are some important messages that you already heard from Sarah, Gail, and Meryl about team building. I think it's important, though, to think about one flaw in my metaphor. And that flaw is as follows. When you go to see a symphony orchestra play, inevitably they're playing a piece of, or almost always a piece of music that may have been written 200, 300, 400, 500 years ago. The problem about modern day healthcare, though, is that we're now in the situation that we are making up the score as we go along. I would rarely come into work knowing what I'm going to be doing in a given day. There'll be something that will be thrown across in front of me that's going to require me to rewrite the score of my day. And so this is one flaw in my metaphor. And so we heard this from Sarah earlier on, and that's this idea that team is not a noun. Teaming is a verb, and this is this on-the-fly coordinating and collaborating across boundaries without the luxury of stable team structures. And Sarah explained these concepts so beautifully earlier, and she talks about that this is really important when work is complex and unpredictable. In other words, healthcare in the time of COVID. And so Warren Bennis, when he reflected on this idea of uncertainty in modern industry and modern industries, this is what he said. He said, I used to think that running an organization was equivalent to conducting a symphony orchestra, but I don't think that's quite it. It's more like jazz. There is more improvisation. Someone once wrote that the sound of surprise is jazz, and if there's any one thing that we must try to get used to in this world, it's surprise and the unexpected. Truly, we are living in a world where the only thing that's constant is change. The great Peter Drucker said the model of management that he had was the idea of the opera. Very similar metaphor. The conductor of the opera has a very large number of groups that he pulls together, but they have a common score. What now happens in industry and healthcare is we're increasingly talking today about diversified groups that have to write the score while they perform. According to Drucker, what you need now is a good jazz group. So when I started to read about this, I wondered what more we could learn beyond my metaphor from jazz. And there's a lot of writings now about the jazz process as a model of collaboration and innovation. This is Stefan Harris, who's giving a TED talk, and he talks about this idea of unpredictability in jazz. And let's listen to what he says.
I have no idea what we're going to
play. I have no idea what we're going to play. I won't be able to tell
you what it is until it happens. So I didn't realize there was going to be a little music before, so I think I'm going to start with what I just heard.
So this is beautiful music. The people who went up onto the stage had no idea what they were going to play before they played it. This is something that would fill me as a classically trained musician with horror, but how do these guys do this? And this is something I tried to unravel. And this is really important, this idea of I have no idea what we're going to play. Again, harps back to some of the stuff that Jim Collins wrote. He talks about leadership teams. He talks about executive teams. He talks about a so-called level 4 executive team. And these are a group of who decide the set of vision for where you want to drive the bus. You develop a map, and then you decide who you're going to get on the bus to help make that vision happen. Collins says that we need to think more. We need to develop what he would call level 5 executive teams. And these are the people who first think about who. They get the right people on the bus, they build a superior team, and then they, once you have that team in place, together figure out the path to greatness. In other words, I have no idea what we're going to play, but what we're going to play is something much more beautiful than if Dan Penny just wrote the script and told you what to do. So it's been written that negotiating through listening with just enough rules is the true art of jazz. And this is where listening comes in. And we heard Gil talk about listening, and I'm going to spend the last few minutes talking about this importance of listening. This seems to be how jazz groups do their business. What tends to happen is that all of the members of the group will play often an introductory opening. And they may have agreed on this at the start, or as you saw with Stefan Harris, they may not necessarily do that. This is called the head. Then what happens is you have a series of improvised solos where the piano takes over for a while, the drums, the percussion takes over for a while, the strings, the saxophone, and they each do their improvised solo. They then have what's called the outhead, which is a summation of that. And then finally, they often have an improvised ending. And so you can see how every member of the group interacts. The problem about this, though, is that we are not very good in healthcare at these improvised solos, which is what Gil said to us. If the percussion doesn't listen to the piano while he is doing his improvised or her improvised solo, he's not going to do a very good job. And so the true art of jazz, getting back to what Gil said earlier on, is this idea about the art of listening. What we tend to do in healthcare, I do it all the time, is that while I'm waiting for my solo, I'm not listening for what the person before me was saying. I am rehearsing the most clever one-liner that I can possibly get in order to put that person down. Not actually true, but I often feel that sometimes that's how we operate. And so this idea of listening to what the person before you is saying and trying to expand on that is the true art of jazz that we need to introduce into our healthcare. Jazz musicians need to be very good listeners. They need to interpret each other's playing, anticipate likely future directions, make instantaneous decisions in regard to harmonic and rhythmic progressions. They may see beyond the player's current vision, perhaps provoking the soloist in a different direction. But none of this responsiveness can happen unless players are receptive. If everyone tries to be a star and does not engage in supporting the evolution of the soloist's ideas, the result is bad jazz. And this comes from Daniel Goleman's book about emotional intelligence. Let's go back to hear what Stefan Harris said about this.
Come up and I dictate to the band that I want to play like this, and I want the music to go this way, and I just jump right in. Ready? Just play some time. 1, 2, 1, 2, 3, 4. Kind of chaotic because I'm bullying my ideas. I'm telling you, come with me over this way. If I really want the music to go there, the best way for me to do it is to listen. This is a science of listening. It has far more to do with what I can perceive than what it is that I can do. So if I want the music to get to a certain level of intensity, the first step for me is to be patient, to listen to what's going on and pull from something that's going on around me. When you do that, you engage and inspire the other musicians, and they give you more, and gradually it builds. Watch. 1, 2, 1, 2, 3, 4. Totally different experience when I'm pulling ideas. It's much more organic, much more nuanced. It's not about bullying my vision or anything like that. It's about being here in the moment, accepting one another, and allowing creativity to flow.
And Goleman talks about this idea of social intelligence coupled with emotional intelligence. And this is this ability to recognize social context in cues and conversations and business transactions. So let's go back on what some of the points I've explored in this talk so far, or in conclusion, really. Zander talks about the idea that the leader's only job is to awaken possibility in other people. It's not to tell them what to do. He depends for his power on his ability to make other people powerful. And if he believes he is all powerful, he's not going to be doing a great job. There has to be between the conductor and an orchestra an unshakable bond of trust born out of mutual respect and, as we've heard, mutual vulnerability. The leaders need to have this balance between this personal reticence, a kind of restraint. Without being self-assertive, he or she needs to be always present and always vigilant. When we think about the Orpheus Orchestra, the members of the team need to consider themselves to be as responsible as the conductor for the future of the team. When I started here first, a lot of people would come into my office and I would say, what do you think we need to do about that, Johnny? They would always say, well, you're the director or you're the chief, it's your job. They don't tend to say that as much anymore. And I'm glad that they don't. Members of the team need to learn how to develop their ideas and then transfer them to a larger group of people. And that's a real skill built on trust and above board conflict. Harris tells us that we mustn't bully our ideas onto other people. If you really want the music to go there, the best way is to listen and to pull from something that's going on around you. And if you do that, you will inspire others and they will give you more. Let's go back to Lully. What happened to him? Well, Lully, unfortunately, one day hammered his stave on his big toe. He got cellulitis in the toe, and he died from systemic sepsis. So I think that this is maybe the most important message of all, and that is that if we try to bully your ideas and bully your teams, we're going to run into trouble one day pretty soon. And so thank you so much for your attention. I really enjoyed giving this talk.
Dan, as always, that was fantastic. It's one of my favorites. Would it be fair to say that Lily had a staph infection?
Yes.
Sorry, that was too easy. I had to do it. That was really, every time I hear it, I just love it more. We've talked about many times, you know, surgeons are like classical musicians. They do want to get that operation done in a consistent fashion each way. And I think us in the ICU tend to feel more as improvisational type people, but we all have to take the characteristics of both without question. I don't know about anybody else, but through the Zoom bandwidth, the videos were a little bit jumpy, at least at my end, but I looked on the YouTube live feed and they're perfect. So if anybody would like to see those videos, and you could really see Leonard Bernstein barely moving. I know, Meryl, you love that part, right? He barely moved, he raises his eyebrow and the entire string section comes in. It's just fantastic. Well, this went better than I would have hoped, and I do want to thank Meryl and Dan and Sarah for joining me today. Hopefully we'll be able to do more of these. I want to wish everybody that is listening today a peaceful and grateful and safe and healthy holiday as we move forward. And I'm going to turn this back to Sasha and Grace to close us out.
Grace.
It was just amazing. Just to let everybody know that we are going to send the link for the certificate and the feedback survey on your email in the next couple of weeks. And what can I say? 4 amazing talks in something that we are not really trained. And this should change. This should change. And what you 4 did today is going to be something very important to all of us, because we need to share this YouTube link to as many people as we can in our field, because this is really mind opener, and we need to think more about it. We are not trained for that. Thank you very much.
Yes.
Sasha?
Thank you again, and I will ask to YouTube creators to try to translate all this speech in maximum number of language for the people, and I think that this message must reach all around the world, because as Grace say, one of the problem of the university that they don't teach us this type of approach, and life is sometimes make it happens. I think that the story of that Meryl put on his presentation about ladies in medicine is very important and serious, and we have to take this very serious daily, not only in the world. Sarah is something that we don't have in Italy, this type of professional approaches you described well. There is no one that is talking to our intensivists or to our people in the ICU. So it's mostly Gil, he loves the mix of cardiologists, anesthesiologists, and sometimes everybody doesn't know his proper role. Is something very difficult. To Daniel Penny, I can stay all the night looking to your speech, because as a surgeon, I think that talk of these things can help surgeon, not other specialty, because I think that we create a golden jail where we close inside because sometimes we are scared, we suffer, a patient pass away. And this is something that change day by day the attitude of a surgeon. It's not a justification, but is what we feel daily, and it's not easy to share a failing case with other colleagues. So I think that different approach with a surgeon with this type of complex specialty in this field is very important. And looking through the orchestra and using also Abbado, that is my favorite, I think that was amazing. So thank you very much. I will ask YouTube and I will inform you to translate in all possible language this day. And thanks a lot. Thanks a lot. It was a pleasure.
My pleasure, Sasha.
See you for Dr. Anderson. Don't forget about it.
Okay. Meryl, I don't know if I ever